very much. Thank you, Mike. Thank you, Joel, for organizing everything. It's a real pleasure to be here. We've got a small audience, so I'm happy to have an interactive talk. I don't really need to lecture at you for an hour. So if you have questions or you disagree with something I say or you want some follow-up or anything like that, just let me know. I'm really happy for that. We can have questions at the end too, okay? Good. So I'm particularly pleased to talk with you today at the Global Health Institute because your institution, and if only a few others on the planet, mine at SICE, the Center for Global Health Studies at the Whitehead School of Diplomacy and International Relations, the London School of Hygiene and Tropical Medicine, their collaborations with the University of Wales and Chatham House in London, are really critical to bringing interdisciplinary perspectives to the practice of global health. And this is critical because global health is still driven by the hard science disciplines of epidemiology and biostatistics. Now, epi and biostats are the foundation of public health inquiry and cannot by any means be discarded. But increasingly, they are necessary but insufficient to ensure the success of global health efforts. And they can't provide answers to some of the most pressing challenges and questions that face global health today. So I want to argue to you today that global health is a deeply political endeavor. The questions of why states act or don't act to support global health, how we elicit greater international cooperation, both in terms of responding to infectious disease threats and helping the poorest people on the planet, are political questions for which epidemiology and biostatistics have few answers. Even the concept of health diplomacy is a highly controversial political topic. Thus, I'll argue with you today that the field of global health must bring the insights from international relations, political science, and public policy to bear on the practice and study of global health. Infectious diseases shape the modern political, economic, demographic, and religious composition of the world. We see this clearly with the impact of the Black Death in Europe in the 14th century, which had an impact both on states, on systems of economic well-being, and on religion. With the Columbian Exchange, which decimated the native populations of the Americas with what were essentially childhood diseases of Europeans, and greatly facilitated European colonialization of the New World. But not only did infectious diseases shape the modern world, but public health has been closely linked with the pursuit of state interests since even before Koch's postulates helped prove the germ theory of disease. Disease took about 25% of Europeans in Africa every year. 25% of the Europeans serving in Africa between 1840 and 1860s. So protecting health was critical to protecting colonial troops and serving colonial economic interests. The consequences of failing to protect soldiers and colonial administrators were clear. The massive French expedition to put down the Haitian Revolution failed partly because 25,000 of the 35,000 troops deployed died of yellow fever. Mariola Espinosa, in a new history on Cuba and U.S. relations and the yellow fever epidemics that spread between the two, it's a fascinating book, calls yellow fever the invisible generals of June, July, and August, because the Cuban insurgents would just melt back into the countryside where the speed of transmission was less and lead the Spanish soldiers to a really dreadful fate of suffering from yellow fever in a place they had been ordered to go and essentially had no help there for. However, death rates in the 1860s began to change. And here I credit Phil Curtin's work at Johns Hopkins for his work on the subject. And the change in these years, the decrease in death rate among colonial troops and administrators, was due to a number of causes. First, they stopped doing ridiculous things, right? They stopped heavy bloodletting, right? Malaria causes anemia. So bloodletting, sometimes half the blood volume over the period of a few days, was really, really bad for people. They also cut down on heroic doses of mercury and opiates that they give people. Mercury, also a diuretic, really bad for trying to recover from malaria. The combination would have killed most people, and it's really certain that the case fatality rate was higher than had no treatment been given. But public health advances helped weed out some of these practices, and most importantly, the advent of a regime for quinine administration for malaria prophylaxis from the day people served on shore and for 14 days afterwards greatly reduced deaths from malaria. So the public health advances changed the colonial calculus. During the 1820s to the 1850s, the question had been for colonial powers, how can we limit our activities to reduce the cost of European deaths? How much empire building would this disease environment actually allow? With the public health advances I've just described, by the 1860s, the question became, how can we protect ourselves in order to carry out the imperial activities we believe are in our personal and national interest? So public health protected colonial troops and protected local workers who helped the colonial enterprise. Improvements in public health also provided a legitimating justification for the colonial enterprise. It was an integral part of the humanitarian and civilizing justification provided both to a country's own citizens and for the international community. And in addition to the notions of Western superiority such activities conveyed, improvements in health were a visible result of some colonial practices, and they were hard to deny for both the colonized and domestic critics of imperial activities. Founding of my school, alma mater, the London School of Hygiene and Tropical Medicine, was not accidentally founded on the docks, the Royal Albert Docks, where ships would come from the colonies. Likewise, the Liverpool School of Public Health, also founded by a shipping magnate, Alfred Lewis Jones, who said the school was an investment and we expect dividends from it. So since its beginnings, public health has served state interest, and in some cases here has really been a handmaiden to colonialism. Now, when I was at London, I'd always get picked on because I'd pick on European colonists, so I was told I had to pick on some American colonial activities too. So it is a great story, the story of the Panama Canal, which I learned in public health school. It's also one of the longest palindromes in existence. A man, a plan, a canal, Panama. I don't know why they taught me that, but I passed that knowledge on to you. So, after the apparently successful, after the successful completion of the Suez Canal by the French in 1869, they were inspired to tack a apparently similar a project to connect the Atlantic and Pacific Oceans across Panama. The technical difficulties they thought they were going to face was the 3,000-foot high cordillera that runs through central Panama. The big problem, of course, and I have a picture of this somewhere where there's this massive demolition project going through the cordillera, and you see the puddles that it's created. And the puddles and the mosquito transmission that resulted was actually the biggest barrier to the French efforts in this area. It was not known at the time how malaria and yellow fever were transmitted, so the French efforts were really doomed to fail. But they did do some ridiculous things. They had screens on their building, and most famously, pans of water were placed around the legs of the hospital beds in the malaria ward, with the idea that it would ward off the bad night vapors or miasmas that caused malaria.